Right. Hi everyone. My name's Asim. I'm an academic GP trainee and I'm also clinical lead of cardiovascular disease prevention for the ICS. So I'm very excited to be able to show you some of the tools and things that we've been working on to try and make things easier for us to manage people's cholesterol. Cholesterol is, of course, an important part of, uh, you know, of managing someone's cardiovascular risk alongside blood pressure, and other things as well. So, these slides just have screenshots from EMIS, but there are equivalent tools for System 1 and TPP as well. Excellent. So for those who aren't familiar with the data quality and GMSS's work, you'll find their searches in a folder called Data Quality NHS GM. Many of you with EMIS may already have this folder on your computer and these searches already available. If you find the CVD prevention lipids folder, you'll come across this screen with a lot of searches in. If you're not familiar with EMIS and you're here just to you just want to find the people that need our intervention, you can essentially ignore this screen and go to the folder practice reports to work through. So inside this folder, there are a number of different reports, and essentially we had a playoff between trying to make the search as automatic as possible and do as much of the sifting and sorting while trying also to be quite safe, and managing those risks associated with searches on primary care records. So what the searches do is that they align exactly to the pathway that Andrew has just taken us through. Anyone who's not had a cholesterol within the last 12 months will go into the top reports. If it's more than 12 months ago, we should probably repeat their cholesterol before doing something further. It's also important to remember that we're talking about secondary prevention here. So just to reiterate that the patients in these searches and the patients that the pathway refer to have already had a cardiovascular event. So that might be tertiary prevention after a stroke or heart attack, or secondary prevention if it's someone with angina or high risk conditions. So these are people who've already had an event, and then that first report is those who have not had an up-to-date cholesterol profile. We've then split the different stages of the pathway by what you would need to do or what kind of intervention might need it for those people. And so everyone who's already had an event should be on a statin, and that's quite straightforward, and that's what the cohort 1 relates to. So it's those people who have had an MI, for example, and have no record of a prescription of a statin on their record. Some of the people with statin intolerance codes may also be in cohort 1, and that's really a safety check. That code may have been placed 15 years ago, and for some odd reason. So it's to bring that up so that you can sense check and re-discuss that with people that you're speaking to. Next slide. If you open up one of the reports, you'll see we tried to put all of the information in one place for you. And you can download these as an Excel to work through if you prefer working that way. You can use EMIS to load the patient if you prefer that way. So trying to make it as flexible for different ways of working. And what you can see here, if you look at the last row, I just pulled this off this morning from my practice. You can see this person, first few rows are for why the search thinks they've had a CVD event and they're in this category. So you can quickly sense check what kind of conditions they've had, when those codes were put down, You'll then get their latest cholesterol, any type of statin that they're on, as well as any statin intolerance or maximum lipid lowering therapy or codes relating to those kind of things at the end. So you get an idea of what that conversation may go like before you have it with the person as well. Great. So this person here, excellent. So thanks. So this person here, you can see that they've had an ischemic heart disease. They've had a TIA in the past. Their LDL is 2.1, non-HDL 2.6. It was done in December, not that long ago, and they're only on simvastatin 20 milligrams. For this person, it's simple as switching it to over 80 milligrams as per the pathway. Great. Next slide. We've also built a template in EMIS as well to try and make things easier. Although it is just lipids for the time being, it does give you as much information as we could relating to lipids and lipid management. So at the top, you'll see what kind of QOF registers, again, why we think they've had a CVD event already. You can't show medications in templates, unfortunately, so we will have to check the medication screen if you were just using the template. Any contraindication codes are pulled in, and then you get some latest blood tests, including when their last LFTs were as well. Yeah, so on the left, you'll see overview, cohorts, and reference. On the cohorts page, you will only be showed information relating to the cohort that patient is in. Next slide, please, Peter. So for this person, this is the same person from that spreadsheet that I've now loaded the template on. And you can see that they're on a suboptimal statin, and there's a clear action or recommendation, at least from the clinical agenda or perspective. In the references page, which is on the next slide, we will build up and add further resources and educational materials and links to useful things as well. Next slide, please, Peter. This is an example of what the cohort page may look like for someone who would be eligible for an injectable, be it PCSK9 or inclisiran. So we try to put as much information here for easy access for you as possible. It talks about the scheduling of when the injections are for inclisiran, as well as the eligibility, as well as when you may want to refer on for PCSK9 inhibitors to your local lipidology clinics. Next slide. Those of you who've been following the inclisiran story over the last year may have come across various statements and things. Andrew earlier alluded to the evidence available for inclisiran, and some of you may have come across the BMA and RCGP statements as well. It is really important that, at least for the time being, that we have that informed consent discussion with people, and that it is documented in writing what we have told them. This is different from other medicines, and hopefully this will change over time as well. But the points that is important to discuss are there, and you can take that yes or no if they consent, and it will write it all into the EMIS record as well. In terms of clinical accuracy. Lower down, if you scroll down, you've got 2 tick boxes for second and third dose as diary entries to make it a bit easier in terms of recall and integrating into your pre-existing recall systems as well. Next slide. And the references section we'll be building up with more material and links as well as we have them. Thank you. Next slide. Finally, I think that the most important thing about this for me, and why we're adopting 1.8 as a standard really in Greater Manchester, is that it is a significant step forwards in how we look at cholesterol. cholesterol is all related to risk. So while this is an absolute target, it is about people's risk, and the people we're talking about here have the highest risk. And it's important that we know about this 1.8, and we have that open discussion with people and come to a shared decision as to what is best for someone, and that in terms of their preferences as well. So this is an alert we're building on EMIS. You may see it in the coming months, and it will just tell you when someone who's had an event is in that high risk category and their lipids are above target.